Welcome everyone on this Friday, November the 6th from the AAHKS annual meeting in Dallas. I've been asked to moderate a industry-sponsored symposium on calipered kinematically aligned total knee arthroplasty with the medial ball and socket implant design. And the company sponsoring this is Medacta International, based in Switzerland with a large presence in Nashville, Tennessee. By way of overview, we are going to focus on the caliper as a quality assurance measurement check in the operating room to adjust the position of the implants to restore the patient's pre-arthritic femoral and tibial joint lines. That is the principle of kinematic alignment, and we do it without the release of healthy ligaments. We're going to begin with 4 15-minute presentations from arthroplasty surgeons at prominent academic institutions. And we've selected them so they can share their experiences in adopting, and they've adopted at different rates, expertise in how they've used it, and then how they teach it to residents and fellows using the medial ball and socket implant design. We're then going to close then with a discussion of several case studies, and we'll get faculty responses to them, and we'll entertain any questions posed during this symposium by the audience. Now, I'm the moderator. My name is Stephen Howell. I'm an orthopedic surgeon. My surgery is performed in Lodi, California, but my office is in Sacramento, so just remember Sacramento. I am a professor of biomedical engineering at University of California at Davis. I started the calipered kinematic alignment technique 14 years ago, and I've done over 6,000 knees in that time frame. I perform over 500 a year, and I do them on all comers without inclusion or correction restrictions. Now, this is our second speaker, Jonathan Spanier, and he is a fellowship-trained arthroplasty surgeon from Cincinnati. He's on the faculty at the University of Cincinnati and Kentucky. His technique and change from MA began to caliper K 2 years ago, and he performs over 400 a year. Similar to myself, he does everybody and doesn't restrict the corrections. And his title of his talk will be Calipered Kinematic Alignment TKA, Simple and Reproducible. This will be followed by David Manning, and he's an orthopedic surgeon in Chicago. He's also professor and chair of arthroplasty and vice chair at my old alma mater for medical school, Northwestern University. We're very proud of their football team. He started calipered KA 1 year ago, so he's early in the adoption phase. He performed about 50 during this COVID year versus 500 mechanically aligned total knee arthroplasty. So he's about 1 out of 4 in the kinematic alignment group. And he's going to discuss the technique in conjunction with the medial ball and socket implant. Our third speaker will be Jonathan Vigdorchik. And Jonathan is an orthopedic surgeon, and he's an assistant professor at Hospital Special Surgery in New York. And he began his transition from MA to K 3 years ago, so somewhat on the newer side, but certainly with plenty of experience. He's performed about 150 calipered kinematically aligned TK in 2020. And he likes to play around a little with technology, PSI, navigation, robotics, but he always checks his cut with a caliper. And 150 knees in New York during the COVID crisis is a very large production this 2020 year. And he's going to talk about how you start with calipered kinematic alignment and how he works within an institution where most of his senior surgeons there are MA and look over him with a watchful eye. Our fourth presenter will be Lucas Anderson. And Dr. Anderson is an orthopedic surgeon in Salt Lake City, and he's assistant professor at the University of Utah. And he started this, I'd say about 14 months ago. I was very lucky that he came out to visit, and we enjoyed each other's company and taught each other about total knee replacement. And he now has performed about 100 kinematically aligned TKA, but without restriction, but he's performed 40 with some restriction on the correction. And then he's had done 10 MA during this 2020. So you can see these 4 surgeons are in different ranges of adoption and different ranges of comfort, whether or not to do all comers and whether or not to limit the correction. And he's going to teach us how he teaches his trainees to do calipered kinematic alignment. So one final slide is to share with you that calipered kinematic alignment with the medial ball and socket GMK sphere implant is FDA approved and has been so for 2 years. And this is actually a printout from the regulatory decision. You can see the device proprietary name is GMK sphere wedded with the kinematic alignment, and there's the regulation number, and it's classified as a class 2 surgical technique. So because there's FDA approval, if you're younger and you're worried about your boards, well, this is an FDA approved technique now. And you'll hear a little bit later about its pros and cons, but you should not feel that if you do the technique and your boards are coming up, that it's something that you could not pass for using this surgical technique. And this just summarizes it in a sentence. The GMK sphere kinematic alignment is as safe and effective as the predicate devices. So this is a good thing for those of you that want to explore this alignment option. So let's not take any more time up. Let's get to the message. Let's get started, and let's hear from our first speaker about calipered kinematic aligned TKA with the GMK sphere component. Thank you very much.
And then maybe, okay, I got Dr. Howell says he can hear me. So let's get started. Perfect. Let's talk a little bit about kinematic alignment. And a little bit about medial stabilized knee. I was asked to talk to you a little bit about why you might consider it, and I'll go through my rationale and then some basic research. So, as purpose of full disclosure, I am a consultant from Medacta. I do get some royalties from Medacta, none of which is related to kinematic alignment or medial stabilized total knee. So not really pertinent necessarily to this particular discussion. So simply stated, what is kinematic total knee? What is a kinematic total knee? I think a lot gets lost in the weeds here. From the 10,000 foot level, a total knee implant alignment concept is what kinematic alignment is, that aims to replicate a pre-disease bony knee alignment on an individual patient basis. And it has reference for femoral alignment, tibial alignment, and total limb alignment. What does it usually look like? More often than not, it looks like a valgus femur, a varus tibia, and hip knee ankle angle or a limb alignment of 180 degrees plus or minus 3, which really, if you think about it, is the same target that we're used to when we consider mechanically aligned total knee. And I want you to keep in mind individual component alignment and full limb alignment as we go through this conversation and others, so that we can make sure we don't cross wires and start to mix concepts. The interest in kinematic alignment comes from the clinical outcomes. The literature is pretty clear in multiple references that about 1 in 5 folks with a total knee arthroplasty, if given the opportunity, will offer some measure of dissatisfaction. Most of them like their knee replacement. They appreciate that they have pain relief from their pre-surgical arthritic condition. But what they're trying to do in their own words, if given the opportunity, is voice a clear understanding that they recognize that they have a knee replacement and not a normal knee. That may come in the form of difficulty with high-end activities like deep stair climbing, squatting, kneeling, and it's reflected in the differences between total hip and total knee forgotten joint scores. Now, there are several studies that show that there are potentially better clinical outcome scores, including the forgotten joint score, in kinematically aligned total knees in the early postoperative period compared to mechanically aligned knees. So that's where the clinical interest lies. And simply stated, what is a medial stabilized knee? So a medial stabilized total knee arthroplasty, like the sphere total knee from Medacta, is a one-to-one congruent medial articulation with an unconstrained lateral articulation at the femoral tibial articulation. And its design is predicated on anatomic and kinematic evaluations done by Pinskerov as well as others. On the bottom left, you can see what you've probably already seen before is the medial side of the knee that doesn't really translate. It is fixed, really, in its femoral tibial articulation from extension to deep flexion. And so is the kinematics of a total knee arthroplasty with a medial stabilized knee, in which you have internal rotation of the tibia with progressive flexion and little motion on the medial side, or otherwise stated, you have lateral tibial rollback, which is normal kinematics. Now, if you're going to listen to me talk to you about why you should consider kinematic alignment or a medial stabilized total knee, you ought to have some idea about my decision-making process, where I'm from, and who I am. So I'm from a small town in Western Massachusetts where not much has changed. And the bottom left, that's an awful long time. That's a couple hundred years ago, and that church is still there. That's the same street on the bottom right, but the other side of the intersection. Not a lot's changed. That can't be said for my orthopedic life cycle, as I call it, from 2003 to current, as a practicing arthroplasty surgeon. So I began, training in Boston with large posterior approach. Short external rotators and capsule repair was the key to keeping them from all dislocating. I transitioned to a mini posterior approach over time, then eventually the anterior approach, which I think has been a clear boon for my patients. They perform better clinically, their outcome scores are better in the short term, their recovery is faster, and I think this is clearly a benefit to my patients. In 2003, that's right near the introduction of highly cross-linked plastic, and I made this highly cross-linked polyethylene articulations early on, about 2003. And that clearly has been the right answer over time if you compare it to other bearing options. And that clearly has been a benefit for my patients. I've used a medial stabilized total knee as my main implant for arthroplasty for the last 7 years. And similarly, and I'll show you some research in a little bit, that clearly has been a benefit for my patients as well as compared to what I did in the past, cruciate retaining and posterior stabilized total knees. And like most of you, I've transitioned from lots of different poisons to aspirin for VTE prophylaxis. And again, that's much easier on our patients and clinically equally efficacious. All right, so I have a history of making good decisions. And when do I make them? I make them early on. I'm an early adopter for most of these things, as evidenced by the highly cross-linked plastic choice in 2003. But I tend to be not just an early adopter, but right past the chasm there, which is what they call the trough of disillusionment. And I think that's exactly where we are today for medial stabilized total knee arthroplasty constructs and kinematic alignment in general. So I'd encourage you to get on board and consider this. What I haven't adopted extra modularity for the purposes of I'm not sure what. Big head metal on metal, bicruciate total knees. I've avoided these things and their unique failure modes. And I think the X-ray at the bottom here says more about the surgeon and the decision-making process than it does about anything else. And I'd encourage you to continue to vet technology going forward. And I think now is the time to consider medial stabilized total knees and kinematic alignment. So kinematic alignment, remember I said at the beginning, it typically, the construct winds up being at 180 degrees plus or minus 3 of global limb alignment. Now there are an increased incidence of traditionally defined outliers with regards to the proximal tibia angle and the tibial implant. But again, you can see this is Dr. Howell's data. This is 73% of his patients wound up being in a neutral hip, knee, ankle. And I think that extremity alignment is important as we consider the next few things I'm going to share with you. This is survivorship. Not only has survivorship been good with kinematic alignment in individual surgeon series or institutional series, this is Australian registry data that showed shape match. They call it shape match there. Shape matched arthroplasty with the same implant done through other alignment techniques has the same survivorship at 7 years. Now, there are shortcomings to large data. So large data doesn't tell us anything about the individual alignment of the components or the overall alignment of the extremity. But nonetheless, the surgical technique has an implant survivorship akin to other alignment concepts, most assumedly mechanical alignment. Now, malalignment of the lower extremity, which overloads one compartment, is associated with progressive arthritis in the normal state, and it's linked to increased cartilage breakdown enzymes in the system, and it's linked to total knee arthroplasty polywear and aseptic loosening. That's limb alignment. Varus limb alignment creates increased knee adductor moment, which we'll talk about in a second, which has clearly been correlated with that increased contact stress and should by choice be avoided. This is knee adduction moment. On the left, you see a neutral aligned extremity, 180 degrees, in the typical single leg stance pattern of 2 to 3 degrees of hip adduction that brings the foot in line with the sacral prominence, so that the ground reaction force is a straight line up, and the perpendicular distance from that ground reaction force to the center of the knee is the knee adduction moment. And on the right, what you see is a varus degenerative knee in which you lose your hip adduction and you have a very long lever arm between that ground reaction force and the center of the knee. And in such, you have a high knee adduction moment. Knee adduction moment in several different studies, normal knees and arthroplasty has been shown very clearly to be nearly linearly related to medial force and strain on that articulation, here represented as an R-squared value of greater than 0.7, which is significant. And that's why just simple residual varus alignment of the tibia and a not neutrally aligned extremity does not improve clinical function in this gait study, nor can it account for the excellent clinical scores of a kinematically aligned total knee arthroplasty. Simply leaving the tibia in slight varus is not kinematic alignment and does not result in improved clinical outcomes. Kinematically aligned total knee arthroplasty reduces the knee adduction force by maintaining, in select cases, and I'll get to that in a minute, a relatively neutral 180 degree plus or minus a few degrees of limb alignment or hip knee ankle angle through tibial and femoral alignment choices that preserves a neutral extremity, hip adduction in single and double leg stance, a short vector from the ground reaction force to the center of the knee, resulting in decreased bearing strain. This also introduces, if you preserve the hip adduction in an extremity, whether it's arthroplasty or not, you alter how the tibia relates to the ground, introducing the joint line obliquity angle. So in a neutrally aligned extremity with a 5-degree varus tibia, you preserve your 2 to 3 degrees of hip adduction in single and double leg stance, and your joint line is fairly close to parallel to the floor, again, consistent with shared strain across a large surface area of the tibia. That's why, if you consider outliers, if you look simply at the proximal tibial angle on the graph on the bottom right, the red line is neutral, and the green lines are barriers or guardrails for malalignment, plus or minus 3 degrees. You can see the histogram of implants falls far to the left, includes many outliers. If you simply look at the proximal tibial angle, if you look at the joint line obliquity angle in a neutrally aligned extremity with a varus tibia, you have very few that are no longer parallel to the ground within a plus or minus 3 guardrail. Kinematic alignment total knee arthroplasty thus better produces normal gait. And that's what's shown here in this guardrailed study. This is guardrailed kinematic alignment in which no component is allowed to fall outside of significant traditional boundaries of plus or minus 5, not 3. But it shows that kinematic alignment had a much better gait pattern than mechanically aligned extremities. It's been linked to improved clinical function in higher end activities such as climbing, squatting, kneeling, the things that our patients complain about. That one out of 5 patients who complain about or offer that they're not perfectly satisfied with their total knee, these are the things that challenge them. So how about medial stabilized knees in general? So medial stabilized knees in our assessment in this cadaver study that we performed was found to have balance and laxity similar to that of a native knee, and was much better than prior studies of the same lab, same investigational study with CRPS knees. And medial stabilized total knees more closely resembled native knee kinematics and far better balance than CRPS knees. When we took it to the clinical realm, in this randomized prospective study that we did comparing medial stabilized total knee to PS knee, we found indeed especially in mid-flexion, these knees were far more stable, as evidenced by our KT1000 values at 30 degrees of flexion. And there was a trend, although not statistically significant due to the numbers of patients in the study, towards improved clinical scores to include the Oxford, the Forgotten Joint Promise, and the Knee Society score. When we broke out the clinical outcomes of these patients, the medial stabilized or sphere total knee arthroplasty patients did better, much like kinematic alignment, did better with weight-bearing flexion or more challenging physical function activities. When you couple the two together, what you get is this study, which I just found in the literature. This is kinematic alignment with medial stabilized total knees at 1 year, showing improved Knee Society scores and Forgotten Joint scores. And this is how we are going to tackle that 1 in 5 patients who offers traditionally some measure of dissatisfaction with their total knee. It's a simple surgical technique and uses familiar tools on the light that you see on the top right. They're metal cutting guides. All we do is measure the bone fragments. We shape match the femur. We measure those cuts. We log those cuts to confirm that we're indeed doing what we anticipate we're supposed to be doing. And this is my personal target. So there is restricted kinematic alignment, in which surgeons make choices about what individual component alignment is acceptable, as well as the total extremity. And then there's unrestricted kinematic alignment, which Dr. Howell will share with you. This is my personal target. This is 2,000 pre-surgical total knees on CAT scan and what their surgical plan would be for an unrestricted kinematic alignment. And you can see my green target box here falls plus or minus 2 on the valgus side, 3 on the varus side for the hip knee ankle angle, and captures a large percentage of those pre-surgical knees. So I think kinematic alignment very easily can be done in a large percentage of patients, incur better clinical outcomes in a reproducible surgical technique, and not venture into outlier status on either an individual component or the overall limb. So in summary, kinematic total knee has an excellent midterm survivorship and clinical scores. Caliper kinematic alignment is simple and reliable technique. It usually results in a neutral hip knee angle and hip knee ankle angle, and that can be chosen. Usually a varus femur, valgus femur, and a varus tibia. The kinematic alignment total knee has a joint line obliquity angle that is near parallel to the floor in most cases, and has decreased knee adductor moment, which is related to medial force and bearing strain, and even with guardrails, as you saw in my personal target box, it is applicable to many. Thanks for your attention, guys, and I look forward to next couple of talks and then a robust discussion afterwards.
View of, the main concern many surgeons have is about this varus tibial loosening. And I think you highlighted it well, Dave, about the adduction moment. And when you do KA, your joint line in single leg stance is parallel to the floor. When you do MA in single leg stance, your joint line is oblique to the floor. And that widens the stance when a person walks. They walk wide-legged, where a KA person walks like a model, fashion model, 1 foot in front of the other, and that's what reduces the adduction moment. So varus tibial loosening is caused by mechanical alignment because 84% of the distal femoral cuts that are made with MA principles put the femur in varus to the patient's pre-arthritic joint line. Then you've got to cut enough valgus on the tibia to neutralize that effect. And if you don't cut enough valgus on the tibia, then you have a double varus deformity, which leads to your high deduction moment and loosening. So surprisingly, I was so worried about varus tibial loosening with KA, and now after 6,000 knees and 14 years, and you say, well, how does that, you look at, if you do 200 knees a year, you have to do 30 years of total knee replacement to get 6,000 knees.
So if we're going to have failures from varus leucine, I should be seeing it, and I wouldn't be up here telling you that it's a rare phenomenon. Our problem is posterior subsidence from not matching slope when we keep the PCL. So David, let me ask you this. While we get up, and we're going to have the video in just a moment. One question. You're sort of dabbling in KA. What has an overall experience been in this first year, and where do you think you'll be in another year?
And my experience has been excellent. I've had no significant outliers, which was part of my inching into the process. And I'm putting together a study looking at kind of target zones for kinematic alignment. I think there are some very obvious things that most surgeons want to avoid. Most surgeons going into kinematic alignment are not going to be interested in X-rays that look too far out of bounds. And I think that's a reasonable way to enter this. And I think entering into kinematic alignment is the same way most surgeons enter unicompartmental arthroplasty. And there'll always be people on both sides of the spectrum. Folks who do a few unis every year, and folks who do 60% of their knees with unis. I think neither is necessarily the right answer. I think the answer is in the middle. That's my perspective that I take to kinematic alignment, and I think that perspective will likely continue. I'm going to actively try to study that. But I think I will always stay with some measure of guardrail or boundary to my individual implant, but really most specifically to my total limb alignment with kinematic alignment. Doing that to date, I've been really happy with the patients that have done it up.
Well, thanks very much, Dr. Howe, for the introduction. I appreciate that, and I'm happy to be part of this discussion for AAHKS 2020. And Medacta supported kinematic alignment and total knee arthroplasty. This is a simple and reproducible technique, and I hope to show you some of that today. I'm Jonathan Spanier. I'm an orthopedic surgeon at OrthoCincy Orthopedics and Sports Medicine, and I work in the Cincinnati area. And like most of us with COVID, I am trying to keep up just like everybody is. And so at least for this particular webinar, I am remote. So this is what I look like. I'm sorry I don't have a camera on me and I'm not present with you in person. But regardless, we'll try to share some pearls and techniques along the way. By way of disclosure here, I really don't have anything that's significant or pertinent to this talk, with the exception that I am a paid speaker for Medacta International. So let's talk about knee arthritis briefly. As we all know, it's a problem. Our patients suffer with knee osteoarthritis. It changes their quality of life and their function. And fortunately, the majority of patients can be treated non-operatively. They don't need any type of surgical intervention. But many of them will fail. And when they do, we know that knee replacement is a good solution. And it's simple, sort of. The reality is that the classic teaching on knee replacement has really been centered around mechanical alignment, and it looks at creating a tibial cut that is 90 degrees to the mechanical axis or the long axis of the tibia. And as a result, that generally takes more bone from the lateral side, since most patients have tibia vera, at least to some degree. And that results in, of course, less bone being taken on the medial side. And in order to balance that in extension, we really need to take more bone from the medial distal femur and less bone from the lateral distal femur. And as a result, when we get to the flexion space, that changes the flexion space as well, such that really our cuts need to be altered, and we need to externally rotate the femoral component, which changes the soft tissue tension and balance. It really looks at only 90 degrees and full extension in terms of balance, and it neglects some of the mid-flexion changes that are happening as a result of this. And most of us, need to do some type of soft tissue release in order to change the tension in the knee. And, this can be difficult. It can lead to patellofemoral mechanical changes and so on. This is an example of a patient that came in the office to see me today, in fact. Thought he was an interesting patient. I brought this up because he's had a ACL reconstruction. He's in his 50s. About 15 years ago, he had an ACL reconstruction. It did well for him, but now he's gone into post-traumatic arthritis. He's here because he's had enough. and he's ready for knee replacement. And looking at this knee, his native posterior slope is about 15 degrees. And that's quite a bit. This is a fairly posteriorly sloped knee. And if you look at his varus valgus position of the knee, I've drawn it in here, but essentially he's about 10 degrees of varus of his tibia, which is quite a bit. And so if you were to take and do a mechanical alignment cut, this blue line represents the 90 degrees. So in other words, sort of neutral mechanical axis for the tibia. You can see just how much tibial bone we're going to be resecting on the lateral side compared to the medial side, really almost nothing. And you can imagine how that would make the medial side very tight and the lateral side very loose, and that would change your soft tissue tension and balance, which potentially would lead to an unhappy knee for a very long time. The reality is that knee biomechanics are complex. There's 6 degrees of motion present in the human knee. We've got flexion, extension, varus valgus changes. We have anterior, posterior translation, proximal and distal translation, internal rotation, and medial lateral translation of the tibia and the femur. And we know that as the knee flexes, the contact point really rolls back, particularly as driven by the posterior cruciate ligament, but it does so asymmetrically, such that the medial side stays more centralized and the lateral side rolls back even more. So if you look at MRI imaging on the lateral side of the knee joint in flexion, you can see how the femoral condyle really rolls off the posterior aspect of the tibia, and really the contact point becomes very posterior. And so this allows for the internal external rotation of the tibia during flexion. And so it's already a complex equation like the mathematics here, but knee osteoarthritis throws another wrench in there and makes it even more complex because there's alteration of normal kinematics. There's changes in varus and valgus deformity, flexion contractures. There's cartilage and bone loss that results in abnormal soft tissue tension around the knee, and it makes it more complex and more difficult. And so what I'd like to suggest is that calipered kinematic alignment is a technique that is simple, reproducible, and makes this complex equation of total knee arthroplasty and the complex thinking algorithm easier. It makes total knee arthroplasty surgery easier. The main focus is really not mechanical axis of the knee. It's not, and the resulting soft tissue release, whether you release the anterior or the posterior aspect of the iliotibial band in a certain type of valgus knee, or whether you do a subperiosteal release of the medial collateral ligament and so forth. It does not pay attention to the hip, knee, ankle angle, but rather it focuses on restoration of the pre-arthritic joint surfaces. If a patient pre-arthritically, or if their pre-arthritic knee hyperextends a bit, it allows for that. If it, if they have a deeper flexion, it allows for that. It generally balances the knee without soft tissue releases and doesn't always necessarily put everyone at 0 to 120. Some people hyperextend and it allows for that as well. The goals are to restore the pre-arthritic condition of the knee, replace the worn surfaces, and substitute for the cartilage and bone loss. It recreates normal soft tissue tension through an arc of motion of the knee. And if you utilize a medial pivot type design that allows for medial conformity, then that essentially mimics an anterior cruciate ligament that's intact, as well as intact menisci. And ideally, it creates a more normal feeling knee. It avoids the problems with mid-flexion instability that happen between 0 and 90 degrees, particularly in the early stages of flexion. It allows for lateral rollback, tibial rotation, particularly in flexion, which is a normal physiologic motion. And it results, several studies now, more and more studies showing higher satisfaction in these patients, lower manipulation under anesthesia, and potentially faster recoveries. So what are we talking about? Where the rubber meets the road, we're essentially taking these pieces of the knee that we've resected or trimmed out, and we're resurfacing, or we're finding and making sure that we have the right thickness in all the right parts, in all the right places for this implant to fit properly. So let's go through that. And if you look at this particular implant, GMK Sphere, Sphere has within it a distal femoral cut of 9 millimeters for most sizes. And that 9 millimeter thickness, essentially we're using a caliper to measure that, and we're accounting for the curve of the blade. So the blade's about 1 millimeter thick, so you lose 1 millimeter of bone for your cut. You may lose up to 2 millimeters of bone for significant chondral wear and sometimes some bony hibernation. And so, all told, you're trying to recreate 9 millimeters. So if you have an unworn side, the unworn side on the distal femur should be about an 8 millimeter thickness on your caliper, because there's 1 millimeter of saw blade, and so that's a total of 9. Whereas if it's worn, the distal femoral resection should be probably closer to 6 millimeters, because there's 6 millimeters of bone there, and there's 1 of blade, that's 7 millimeters, and there's 2 more of cartilage loss, that becomes 9 millimeters, and that recreates the 9 millimeter distal femoral implant that you're implanting or placing into the knee. Same thing with the posterior cut. Here's my hand kind of holding a bone here, and so posterior femoral cut, the goal is to reach 8 millimeters. The tibial cut, the goal is to reach a minimum of 10 millimeters. So you can see here's an example of a tibial cut that's fairly symmetric across the medial lateral side. I think this is actually looking at it from the posterior side, where this is some of the attachment for PCL. But essentially, if this is the medial aspect of the knee and this is the lateral aspect of the knee, then here on this medial side, we have, we're looking for a minimum of 10 millimeter thickness cut when we account for chondral loss. And so our goal is for this to be a relatively symmetric cut, depending on how much chondral loss there is, how much cartilage loss there is. If you look at the side of the tibial plateau after you've cut it, and you imagine a line that goes across the joint surface and another one that goes across the cut surface, those 2 lines should be parallel. If they are parallel, then that tells you that along the posterior aspect of the knee, you've not over-resected in the posterior tibia, and so that results in an appropriate flexion gap or appropriate flexion space. If, on the other hand, your cut looks like this, and the lines are diverging as you go from anterior to posterior, that tells you probably cut too much posterior slope, and you can accommodate for that by cutting a little bit off the anterior tibia, leaving the posterior tibia alone, and then putting in, say, for example, an 11 millimeter or a 12 millimeter thick polyethylene. On the other hand, if you cut the other way, so you haven't cut quite enough posterior slope, then you've tightened your flexion space. So this would be an opportunity to take your saw blade and take another millimeter or 2 of posterior bone, depending on what your original cut looks like. And this is not based just on visualization, although visualization helps, but it's based on what you caliper measure, what you're measuring. It tells you exactly where you are. Same thing with the patella cut. Depending on the thickness of your polyethylene, I think a sphere has a 10 millimeter polyethylene thickness for the patella component, but you can cut up to 10 millimeters. Your goal is to really get as close to that as possible without over-resecting the patella. Obviously, you don't want to over-resect. You don't want to increase the risk of fracture. But the same concept. A couple of tips for this. What I do is I complete the femur first. I think that helps you to see the tibia more clearly. I think planning on retaining the PCL is helpful because the posterior cruciate ligament is extremely helpful for rollback and drives normal kinematics and hopefully normal mechanics of the knee. But always assess for the stability of the PCL after you've done your resection, because it is possible to damage the PCL during the tibial resection. So be careful there. I use x-rays as a basic guide to help me line up my jig, particularly my extramedullary guides. And then we know what the plan is. It's a 9 millimeter, 8 millimeter, 10 millimeter, up to 10 millimeter. All these are the distances and the thicknesses of the implant. So once we know that, we confirm what we've removed with calipers. That's absolutely key. So here's an example of a patient who's got a varus knee. He's got wear on the medial side. He's on for total knee replacement. I'm, there for surgery. And essentially, if you look at the X-ray from across the room, I use the X-rays in the room to decide about how much varus to start with, so I'm in the ballpark. So here's an example. Here's me. Here's the extramedullary tibia guide. And what I'm going to do is look across the room where the computer screen is. Can't quite see it, but the X-ray would be up there across the room. And I'm going to immediately say, okay, so varus knee. I ask my assistant, step back, let me look at the X-ray, and then I adjust the base over immediately from a neutral position so that I know, okay, this is a varus knee, that gets me in the ballpark. And then as I'm making the next decision on how I cut, you see I'm using a 10 millimeter guide because that's the minimum thickness of the implant. And on the lateral side, there's not a lot of wear, so I'm going to do I want it to sit flush on the lateral side, but on the medial side, I want it to be just off the bone, just a little bit off the bone. Play this video one more time, but essentially my goal is to recognize that there's wear on the medial side. I want to plan on putting a couple of millimeters less than 10. So, for example, I'd probably take about 8 millimeters off the medial side. So you can see that I'm showing you that it's sliding back and forth and not actually touching the bone on the medial side. And so now I'm happy with that. I'll pin it and move on. Here's an example of what I would do after I'm removing this section of the proximal tibia. There's significant wear along the medial side there. You can see it, anterior medial wear. The lateral side's mostly intact. We're looking at this from the side, and you can see that the slope is matching the line there is matching the line there. So the two slopes line up, which tells me I have not over-resected the slope or under-resected the slope. And of course, I'm taking measurements using a caliper every single time with all these parts, trying to understand what is the thickness, and generally measuring near the base of the tibial spine. So hopefully you're going to end up with knee resurfacing that looks something like this. You get an implant that the thickness of your patella when you're finished with it is the same as the thickness of the patella when you started, and the distal femoral cut and the joint line is in the same position, and the posterior slope of the implant is similar to native posterior slope, and the posterior femoral cuts are the same as the posterior posterior thickness of the femur as well. And same thing here. You can see the thickness of the the patellar component is trying to mimic and match this. And then you can see that this particular gentleman who looks like about 6 degrees of varus, we tried to recreate some of that. This x-ray is not quite as long, so you can't quite see, but you get the idea that this implant is in a bit of varus, just like his native joint would be. And so I don't worry particularly about putting these implants in some varus, because the position is really relative to how we're standing, whether we're walking in single leg phase or running in single leg phase or standing still. And the reality is that as we go into single leg phase, our center of mass and our center of gravity shifts over the leg that's on the ground, and the oblique joint line then becomes more parallel to the floor and to the ground reactive forces. And so I think this is a very sound way to do knee replacement. You're mimicking the native anatomy of the pre-arthritic condition of the knee. This is a technique that makes sense. This is a technique that patients greatly benefit from, and can be done with standard implants, and requires simply the use of a $5 caliper in the operating room and the surgeon's technique. So anyway, I hope this is helpful to you. I appreciate the time, and I appreciate being part of this esteemed faculty. And best of luck to all of you. I'll turn it back over to Dr. Howell and the panel. Thank you very much.
Good morning. I'm Lucas Anderson. I'm at the University of Utah, and I was asked by Dr. Howell to present on teaching calipered kinematic alignment total knee to trainees, many of who have a healthy dose of training in mechanical alignment, gap balancing, and measured resection. So my journey has included measured resection training with predominantly strict mechanical axis alignment. I did learn some gentleman's varus from Dr. Aaron Hoffman, who's here at University of Utah for years. Good morning, I'm Lucas Anderson. I'm at the University of Utah, and I was asked by Dr. Howell to present on teaching. In fellowship, I learned gap balancing, mechanical axis. Early in practice, I did mechanical axis with gap balancing with PS implants. I transitioned to some KA leanings on the femur and tibia and found that I had less releases. We kind of coined the term gapomatic. And during that time, I was transitioning from PS to CRCS. And then the last year and a half, I've been doing calipered KA with restricted KA for outliers, patients with tibial varus greater than 5 degrees or so. During that time, I've also transitioned from CRCS to more of a medial pivot design. So I wanted to first talk a little bit about gap balancing and measured resection. They say they have the same goals, but just different techniques: restoration of mechanical axis, symmetric ligament balance. The controversy over the years has been which technique best accomplishes these goals. My thought is that neither of them are intuitive or reproducible, at least in my hands, and it's not easy to train trainees as well. So a measured resection definition is that the bone is removed from the uninvolved femoral condyle and tibia equals the thickness of the prosthesis. I think this is just sort of true because of the joint line obliquity. The femoral rotation is based on bony landmarks, but this is only sort of true because we know from different studies that epicondylar axis and White-Size line is not very reproducible. The ligament balancing occurs after the cuts with the trials in. Advantages are that it maintains the joint line position, although not the obliquity. Hopefully it minimizes mid-flexion instability and alterations in patellar station. It's been noted to be intuitively easier to perform, and efficiency is benefited by femur first and then transitioning to the tibia. I think the disadvantages are the unpredictable rotation of the femoral component, potential for asymmetric flexion gaps with associated condylar liftoff or lateral laxity. My closest mentor and senior partner, Dr. Peters, published this study back in 2001. I've read it multiple times going on his rotation. It was standard reading for the residents. It's 4-step versus 5-step ligamentous releases in cadavers. There's a plethora of articles, book chapters written on ligament releases. They are hard to understand. They're hard to memorize. They're harder to actualize in surgery with unpredictable amounts of release. Turning to gap balancing, the goal is to create equal and symmetric flexion extension gaps by rotating the femur after balancing an extension. The flow is mechanical cuts on the femur and tibia, balancing extension, and then tensioning the ligaments and rotating the femur accordingly, regardless of bony landmarks. Stated advantages of this technique are equal and symmetric gap balances in flexion and extension with a minimal risk of instability and condylar liftoff. Disadvantages, the flow of surgery is disjointed, it goes back and forth, tough to be efficient, and external rotation of the femur can lead to notching, which can lead to upsizing of the femur. Then you get overhang, medial to lateral. Then you can go back and have to recut your distal cut and flex the femur more in order to downsize and appropriately match your femur size to the anatomy. So, and there's also a big list of releases that you could potentially do to try to get balance with gap balancing as well. So caveats, you balance an extension before you have good access to the posterior fights, and then late removal of fights can change your balance. So sometimes you find you're chasing your tail as the case goes on. So overall, I think the goals for total knee the last 40 years have been to relieve pain, restore alignment, improve stability, functional anatomy, but unrestricted sports and exercise is huge. It's a huge desire for patients that we're seeing every day now. This article has been quoted over and over again, 1,700 primary total knees, 20% not satisfied, expectations not being met is the biggest predictor of dissatisfaction, which is 5 times greater than hospitalization for a post-op complication. My own division's attempts at improving patient outcomes has included saving the ACL, patient-specific cutting guides, robotics, pushing the limits with partial knee arthroplasty. So, and none of them have really shown an improvement on the standard. So my attempt at improving outcomes has been to obey the 3D femoral anatomy with calipered KA. I think it's ligament friendly. I've done little to no releases for a year and a half, which is addicting. And I think it's low cost. It doesn't require expensive technology or other techniques that slow us down. I think ligament releases for me in 2020, the overall value is somewhere between a razor blade and a bra. So I'm addicted to not releasing ligaments. So standard technique, trying to account for the cartilage loss, taking only enough bone and cartilage off to replace the femoral component itself. Resected bone should equal the implant thickness minus the saw curve minus the cartilage wear. You should know the thickness of your implant that you're using because it varies. We complete the cuts in flexion, all femur first is kind of the standard KA technique. You need to account for cartilage loss, specifically in the valgus knee where you might have some posterior lateral condylar cartilage loss. We remove those wafers, we measure them. If they all line up, then usually we move on to the tibia. I think this technique is truly the true measured resection technique. My fellows have gone to measuring these pieces out, putting them on the back table. I can come in partway through the surgery and know where we've been. Usually if we caliper the tibia, we have a pretty good idea, and that gives us confidence about doing recuts as well. So we mark this, put this on the white erase board. It's easy to reference during the case as far as our guide. I think it's easier to do quality assurance with KA because you can actually measure these pieces, whereas a measured resection knee, you really don't know what the pieces are supposed to measure. This is an algorithm that Dr. Howell has published with Medacta. It's very straightforward. It's not confusing for residents and fellows and quite reproducible. So final balancing is usually done on the tibia, probably greater than 95% of the time in my hands. If they are tight medial, both in flexion and extension, it's a varus tibial recut. Similarly, on the lateral side, if they're tight, then it's a valgus recut. Usually I'm doing a 2-degree recut and then increasing my poly size by 1 millimeter or 2. Here are some pictures shared by Dr. Howell showing the 2-degree varus recut guide. It's quite elegant. If you want to do a 1-degree varus recut, you just place an angel wing under. Honestly, a lot of the time I'm just freehanding a 1 millimeter recut. If you have isolated medial or lateral instability, that's usually a femur problem. It means you either messed up your femoral cuts. And if it's an extension, I usually just use a little cement balancing and leave the femur up a couple millimeters and let it harden. If it's in flexion, then I think it's a little bit more difficult. You have to either upsize your femur and rotate a little bit before you do your lug drills, or you can, if you're trying to keep the same size femur due to size constraints, then you need to do your 4-in-1 recuts. So here's a fairly significant varus total knee. We ended up doing straight KA. The overall limb alignment is quite satisfactory. The joint line obliquity is oblique. That said, I have also been doing some flamingo views or single stance views, and almost all the time that joint line is parallel to the floor with a single leg stance. So I do have a learning curve. It's usually 1 or 2 errors that I make. Usually it has to do with not obeying the math on the femoral side or not doing enough varus on the tibia. So I'm still learning to recut the tibia enough to go straight. So here's a conversion of a uni to a total. I usually leave the parts on and make my cuts and then complete them with the parts off. I use that distal lateral wafer to recreate my rotation. In this case, I used a stem. I probably should have used offset. I probably shouldn't have used a medial augment. And I did straight KA on the femur, but I just didn't go far enough varus on the tibia cut. And so he ended up in a little bit of valgus, which is not really my goal. So if you start KA you can't really change midstream. You got to keep going. So efficiency with trainees. I was doing gap balance total knees with the tourniquet times around 63 minutes. I let my trainees do most of the surgery and just try to direct traffic. Instantly, as soon as I started doing gap balancing, my tourniquet times dropped by 5 minutes and then 10 minutes as we became more efficient with the technique. So even with rotating trainees coming on and off service, I feel like the efficiency of doing femur first, the calibrated technique is very straightforward. Additionally, comfort with trainees. I think it was usually around 6 months before I could trust fellows to balance a knee with gap balance technique. The releases were a little bit more difficult, harder to trust, and harder to rescue if you over-release. And whereas with KA, I feel like even 6 weeks in with new fellows, the simplicity of the technique, the instant feedback with the measured calipered wafers that I can check mid-case, and then it's very reproducible and calculated with the tibial recut. And I have an easier time handing over the tibial recuts than the knife for a ligament release, just because if you overcut or undercut, you can redo your tibia cuts a few times as long as you're conservative with your initial cut. So overall, I think mechanical alignment and gap balancing, whether measured resection or gap balancing, are the traditional standards in total knee. I think I'm really encouraged by how KA is growing. I see more and more respected surgeons adopting this technique. There's growing scientific support. The clinical data is promising, and I'm looking forward to more being published. I think teaching calipered KA to trainees is common sense. It's reproducible. It's efficient. It's intuitive for trainees to understand. I would just say that caution is probably warranted in young surgeons adopting it, especially during boards collection. I welcome any thoughts that you guys may have.
Hi, everyone. Thanks for joining us. I'm going to talk about how do I introduce kinematic alignment to your practice, especially when you're surrounded by 31 other arthroplasty surgeons who may be looking at you. And that's only in my building, not to mention 5 other institutions within a 2-mile radius of where I work. So a very difficult environment. I have to say it's been quite a journey, and I think it's really important to do these types of webinars and talk to surgeons like the ones you're hearing today to learn from their experiences, to share in this, because it's an exciting journey that I feel like we're on. Disclosure-wise, I do get consulting from Medacta. But my real disclosures, I think, are that I work at HSS. HSS is a place where we do 12,000 joint replacements per year. That's about 50% total knee replacements. Posterior stabilized, 95%. And those 5% that are not posterior stabilized are usually CR or some sort of ultra congruent or cruciate sacrificing type of poly. Mechanical alignment is 95% of the cases, and 5% of the time it's not mechanical alignment. And I would say that probably 4, if not 4.5 or 5% of those are my kinematic alignment cases only. And we do have 31 adult reconstruction surgeons. So quite an interesting environment to introduce something that's completely upside down and backwards from what they used to do, basically since the 1970s in total knee replacement. Let's talk about a little bit about the history of total knee replacement. 1951, we had the Waldius hinge. In 1960s, Gunston, who was actually one of Charnley's partners, started introducing his prosthesis there. All of these were big failures. We started looking at polycentric knee replacements. And then the first total condoler was done in HSS in 1974. So quite a long history at our institution in terms of posterior stabilized knee replacements. Although interestingly, they started really with cruciate sacrificing. Total condoler involved into IB1, involved into IB2, and into our modern day knee replacements. So a long history, and a lot of these guys are still in practice. You know, I have some partners who are in their 80s who've been doing knee replacements since before I've been born. So now I'm coming in and trying to teach them or talk about something differently. So it's been quite an interesting experience, and I'll share some of that with you today. This place has always been a mechanical alignment philosophy. Hip center, knee center, ankle center. Make your cuts perpendicular. Rotate your cuts perpendicular to white sides line, and everybody's happy. Once you set your bony cuts, I mean, this is a very measured resection type of institution. Once you make your bony cuts, we've all learned from Dr. Insall, who was originally at HSS, that total knee is a soft tissue procedure. So most importantly from what they did was the soft tissue balancing. In the 1970s, it was really huge soft tissue releases, enormous medial peels of the entire MCL, distally around the back of the tibia. Same thing on the valgus side. It was really about an all or nothing sequential about it. Big releases balanced the knee. But you have to remember that back in the 1970s, they weren't doing total knee replacements on runners who couldn't run a marathon but could walk fine. These were rheumatoids. These were huge deformities. These are people who were wheelchair bound. So it makes sense that they started with this type of relationship. And they only had 1 or 2 sizes. It's not like they had 10 sizes on the shelf to match. They were worried about flexion gaps, ligament gaps. So this really was one of the most important parts of their knee replacement, was the ligament balancing to make sure these knees didn't dislocate and that these people could somewhat walk. Also, the expectations of the patients were much different. If you're a wheelchair-bound patient, maybe all you want to do is walk. Now we're getting into more patients who want to play tennis, they want to play golf. It's really a different world than it was back in then. 1990s until the present, they start doing sequential ligament releases. On the varus side, they start with the deep MCL, sometimes the superficial MCL, and we're taught from residency, where do you release to get what? Where do you release to affect the medial extension space? Where do you release for the medial space and flexion? All sequential releases, all ligament balancing. So this is the environment that I rolled into in fellowship, and now I'm starting to evolve from in my current practice. So my keys have been really do this in a sequential stepwise fashion, baby steps. I'll talk about patient selection and what patients do and how I kind of evolved through this. And it's been very similar actually to what you've heard from the previous speakers. Don't make this about marketing. Otherwise, it's going to turn into a very heated debate, direct anterior versus posterior. It almost seems in our institution, this type of thing, when you start talking about anterior hips versus posterior hips, it's like you're attacking somebody's religion and their faith. It becomes a heated, emotional discussion. I think that happens with marketing when people are nervous that you're trying to steal their market share. So if you make it not about marketing and you make it more about patient outcomes, evidence-based integration, then you can start slowly evolving this. I happened to be in an institution where there was an article about ACL repairs that was placed in the New York Times. A week later, a bunch of surgeons took an ad out in the same newspaper against that article. So a lot of very, very difficult working environments here. So baby steps, patient selection. Don't make it about marketing. There's always going to be haters, non-believers, but then there'll be you who's going to be proving them wrong. I actually think journal clubs may be the single easiest way to start introducing this to your colleagues. Pick some well thought out papers and just review them. Talk about pros and cons, look at the evidence. You'll be surprised to see how many people know about kinematic alignment, but only worry about varus tibial loosenings, but they don't actually look at the literature. They don't know anything about knee adduction moments. They had nothing about the survivorship of these. So a couple key selected articles really help people start evolving their thought process and maybe think about that what you're doing may not be completely crazy. And then, if there's any naysayers, just say, have you ever left your tibia or femur in a little bit of varus to balance a tough knee? That's a baby step. That's definitely not kinematic alignment, but it's a baby step in terms of them actually buying into these concepts. We polled all 31 surgeons. 100% of them said that they had done this. So they're not against this. They may not be attuned to all the literature. They may be afraid of what this may seem in their patients. So you have to really get at the underlying motivations of why people don't want to think about kinematic alignment, why they're afraid of it. And it usually has to do, like I said, with trying to steal patients away, trying to steal market share, because everybody needs to put food on the table. So let me start with patient selection. This was my step. First, I started this in varus total knees only in males and no deformities greater than 10 degrees. I felt that was a pretty safe boundary. It was completely arbitrary, but it would allow me the opportunity to play with some valgus in my femur, some varus in my tibia, and leaving limbs in a couple degrees from the mechanical axis of the limb. So really not a huge deviation from what I was already doing. And I felt very safe doing in those particular patients. Males have great bone. As you all know, we typically don't have a lot of tibial failures in males unless they're incredibly obese with BMIs over 40. So I felt very comfortable that I wasn't going to have any tibial failures in this type of population. Once I saw that those people did great, I slowly evolved. I went for males and any deformity. Really, I was thinking about a max tibial cut in about 5 degrees. I wanted to limit my boundaries there. Again, baby steps to progress what I'm doing, but in a nice hard bone male where the risk of any type of complication is very low. Once I saw they were doing okay, the next step was all varus TKAs, male and female. And I'm still not really understanding in the valgus situation. I think a valgus pathology might be a little bit different. These patients don't do as well. And it's hard for me personally to understand leaving somebody in valgus. I know they've been there all their life. So I think this is an interesting point of discussion in my evolution of how to understand that valgus knee and how to treat those patients a little differently. But why I looked at those first stepwise progressions, males, small deformities, I looked at this paper, 222 kinematic total knees, 97% survivorship, free of all-cause revision. The range of alignment had no effect on the survivorship, so even the ones that were huge outliers survived just as well. And if you take out all the valgus ones, and you look at that, 73% versus the 8 varus outliers. So 73 out of 80 is actually 91% of my cases would be within plus or minus 3 degrees if I excluded all the valgus ones. So that's not really a lot of patients, and you can feel very comfortable that the majority, almost all the cases you're going to do, are actually within a very close boundary. And if you talk to any of the mechanical alignment guys, they're all using conventional instrumentation, and they accept plus or minus 3 degrees. That's their target. So it's not really 0, it's minus 3 to plus 3. So if I'm doing that with kinematic alignment, I'm 91% of the time hitting a mechanical alignment target. Nobody's going to think twice about that because my knee x-rays are still going to be okay. But it's the joint line obliquity, it's that knee adduction moment, it's those things that are changing that are really affecting the outcomes of my patients. But I think if you think about it like this is an easy way to step into kinematic alignment and start doing you're really not doing much differently except cutting your femur better and cutting your tibia better. After that, very similar data, 100 kinematic alignment knees, only 4 femurs were outside of 5 degrees of valgus. So 96% of the femurs were fine. Only 12 tibia cuts were greater than 5. And if you looked at all the ones that were greater than 5, the range was 5.2 to 6.8. So up to 7 degrees almost take care of 100% of the knees. 5 degrees, really, I don't think is that scary. 6 or 7 may be a little bit more scary. But if you think about that, almost 90% again of your knees are going to be exactly what you were doing before with mechanical alignment. So you're not doing anything different, just doing a better job at what you are already doing by making your joint line in the right orientation. I also decided to set up a research program about this. I was fortunate that we have an incredible biomechanics lab with tremendous experience with this. So we're starting to look at, are all bones the same? Should a female get KA with a lot of varus versus a male bone? Is it the same for cementless versus cemented? We're trying to look at this through gait, through previous literature. Every aspect of this is being studied. So when somebody comes to me and says, why are you doing this? I can say, well, we're studying it. I'm keeping track of all the patients. I have an enormous biomechanics program around what we're doing, looking at bone risk of failure, looking at varus stresses and micromotion on the implants. So it needs to be studied, and we need to figure out if what we're learning from Dr. Howell is true or if it's a bunch of nonsense. And we're starting to lean more and more to that he may actually be right. So why kinematic alignment for me, really? When you see these patients back in the office and you do it right, and I can tell you in the beginning, sometimes you don't get it perfectly balanced or perfect lax. That total knee behaves exactly like a regular total knee replacement. But when you do it right and you nail the kinematic alignment and you restore that patient's native ligament laxities, their first post-op at 6 weeks, they're doing absolutely fantastic. The total knee patients are behaving like total hip patients. They're walking up and down stairs, reciprocating stairs. They don't have any limp. And then you realize that there's something to this. So that's really what's in it for me. I want to be able to figure out a way, how do I get it right every time for every patient? And we're slowly evolving the way we're doing this in order for me to make that happen in my practice. So I hope that was some valuable insights and to really explain my journey through this and why I'm doing the way I'm doing.
All right, how about now? It worked. Jonathan, can you hear me?
I can.
Good.
Can you guys hear me?
We've got a little reverberation here. I'd like the other two panelists, Dr. Anderson and Dr. Manning, to enable their video. And I see Dr. Manning's up. I'll start mine and go. Try to get my monitor in the right spot. There we go. And Dr. Anderson as well. So I want to thank all of you for what has been a little difficult with the technical side, but presentations were outstanding. And Jonathan, I wanted to compliment you on sort of sharing a difficult time trying to make a change at an institution and doing it in a responsible way. So what I thought I would first do, we were going to have question and answers coming from the audience, but I don't think, or at least from the internet audience, and I don't think that's happening. So let me ask first if there's any questions from our audience. And no one's, yes, we've got one. Yep.
For a knee that has a large loss of extension of flexion contracture, is that still usually will work out with just the kinematic alignment and you can get the extension back?
Well, let me share a case. Can I do that? It's a good segue. Let's see if I can do this. I wanted to bring up some cases, and when I get a question about varus valgus or whatever, I'll bring up one that I struggled with, and then I'll ask my panelists what they think. And this is such a patient. This was a guy, he's no longer with us, Lester Milcast. That's what happens in your practice when you have a patient who teaches you something, you never forget them. And that's Lester. So Jonathan, early on, you were a little, you approached this gradually, which is a responsible way of doing it. So you had limitations in the varus valgus. Is this someone that early on you might have been reluctant to do? And is it still someone that you're reluctant to do?
So early on, I think I would have put the femur exactly where I would have put it. I would have put my tibia basically to 5 degrees, and then I might have done 1 or 2 pie crusts of the MCL, something in my stepwise ligament releases in order to get that knee to a balance that I felt was appropriate. Now, I still struggle with that word, appropriate balance. I don't really know the native ligament laxities on this kind of guy, but I assume that when you do your proper, just regular medial exposure, you take off all the osteophytes, you should very reasonably be able to balance this one in extension. But I think you may have to go more than 5 degrees of error. So early on, I would not have gone more than that. Now I probably would have accepted whatever he had.
Well, let's go through it. So this guy's 73, and in the operating room, you can see the degree of varus that he has, and then I believe you can see the radiographs here, the flexion contraction. Let me go back to the radiographs. And so I'm going to ask, I'll ask Dr. Manning, do you think there's any substantial bone loss on the femur at 0 and 90?
Yeah, so I'm looking at the AP at the moment, and I think there may be some small amount of anterior medial bone loss, but the natural height of the tibia, there will be a relatively unworn area of bone that can be referenced for normalcy. Yeah, that's about it. I prefer, frankly, I'd prefer a 3-foot film. I can't look at that and know what I want to know, because I'm interested in the proximal tibial angle in the way I approach things, and I don't feel comfortable measuring it in that short view tibial rotated in the plane of the film radiograph.
Yeah, that brings up an interesting question or comment, that the principle on the femur, which holds pretty true unless you've had AVN or maybe you've had a septic knee when it has been actual bone loss. At 0, where we reference with the distal referencing guide, you saw that in the presentations, and we do a posterior referencing guide at 90, bone at that position is preserved. Even in the worst knee, you'll see, because a terrible knee like this doesn't extend. So if it doesn't extend, it's hard to wear the bone on the femur. And the femur, as you know, is a convexity, and the tibia is a concavity. So no matter what position of flexion the knee is in, the tibia gets beat up pretty much throughout the motion arc. But the femur is spared at 0 when there's a big flexion contraction. At 90, the person's sitting down in a chair. We don't do many loading activities at 90. So you can be pretty confident. And if you have a doubt or you're worried, get an MRI and you can check there. So this was his flexion contracture. And at that time in 2006, I'm thinking, I wonder if I have to take 2 more millimeters off the distal femur to get the knee to extend.
Terrible idea.
What do you think about these flexion contractions now that you've expanded your indications, Dr. Bedorchik? Do you find that
so in my institution
stretch out pretty well when you do the cuts kinematically, or do you think that there's issues?
Even in a mechanically aligned total knee in our institution, they have never taught to take 2 millimeters of distal femur for a flexion contracture. It is always taught to do what you normally do. Take 9 off the medial side, release the posterior capsule, take off the posterior osteophytes. You never take more distal femur. Only on some crazy cases where you need to do that in order to balance your flexion space by increasing your extension space. So I know this guy, that's barely a flexion contracture.
Knees that have a severe flexion contracture are properly managed with kinematic alignment by following the rules of removing the thickness of bone and cartilage from the distal and posterior femur to match that of your condyles or your component after you compensate for the wear of the cartilage when present and the curve of the blade. I mean, does the extension automatically get restored to, in my view, a little hyperextension, which is what I like to see.
I'm not sure it's a necessarily a kinematic alignment thing. I think it's more of a posterior capsule release and posterior osteophyte thing. So this is completely irrespective.
We just did the operation with back then PSI guides, and we used MRI. So we never knew where the hip or the ankle was because we never imaged it. back in 2006, 7, 8, and 9 with the old Otis knee. This is the medial compartment, and you can see all the fluid that's filling in where the cartilage is missing, and yet the lateral compartment is pretty well preserved. And if we look at the cartilage, you can see that it's all worn distal medial, but posterior medial, posterior lateral, distal lateral, there's some stuff there. So if we do a circle fit to the circumference of the subchondral bone from about 15 to 120 degrees, it's pretty circular there, but not from 0 to 15. And the same circumference fits the other side. So there's, by definition, no bone loss where we reference. So then we went ahead and planned our cuts. So this at that time was a Vanguard knee. It was 9 millimeters thick distally, excuse me, and 9 millimeters thick posteriorly. So we expected our distal medial cut to be 6, adding 1 back for the thickness of the blade and 2 for the cartilage, which would get us 9, and the lateral would be 8 plus 1 for the thickness of the blade would get us 9, and our 2 posterior resections would be 8. We add back a millimeter, we get 9. So when you open the joint, you shim it, if you will, and that's what I'll tell the patient. We're going to shim your joint open. For every millimeter that you shim the joint open on the medial side, on average, you move the ankle 6 millimeters lateral in a varus knee, or valgus would be the other way. So if you're going to open it 4 millimeters, reasonable length tibia, you're going to move that ankle out of the varus alignment 24 millimeters. So let's look at it. So there we're going to open that 4 millimeters. We tilt the knee. We bring it back underneath. And you can see now at the ankle, the displacement of the center of the ankle went out of varus. And consequently, when you look at this, that distance is about 24 millimeters. And you can do this anytime you want with your image software that we have now. But this is what it looked like. In the operating room, I was so pleased. This probably maybe was like 10 or 11 of the knees that I did at the time. The extension came back with no releases, which shocked me. We got nice flexion back. And this is what he looks like when he comes back in at 6 weeks. So what do you think about that alignment, Lucas, looking at the leg?
Looks beautiful.
So it looks like the other side. So if we look at the knee short leg view, how about this? What do you think, Lucas? Would this have worried you before you started the kinematic alignment journey over the last couple of years?
Yes.
Dr. Manning, does this still worry you?
No, again, I'm a stickler for longer films, but looking at that film, that's 5 degrees or less. It doesn't alarm me.
Okay, so your wish is my command. So I think Lucas, let me ask you: when you look at this long leg, tell me what you think about the joint line, how it is now with kinematic alignment, and how it would have been with mechanical alignment.
Yeah, I think if you look at more of these kinematics, you start to get used to the joint line obliquity, but you've perfectly restored the overall limb alignment.
And that's why this works, because we're really not, you look at in a single leg stance, you would have the pelvis and the joint line and the ankle parallel to the floor. But when you're switching the joint line around from pre-arthritic, then the ankle's not right to the floor, the knee's not right to the floor, your adduction moment goes up. And what would have happened in this knee is this distal cut on the femur would have been in varus to that position. It's actually cut in valgus compared to the mechanical axis, but it would have been cut in probably 3 or 4 degrees of varus, which then predisposes you to the high adduction moment that was nicely outlined by the speakers. Another question.
Yeah, so Steve, can you hear me?
Yes.
Yeah, if you go back to your previous slide, that case is the sweet spot for kinematic alignment in my last slide, my target, right? So you have You have a hip knee ankle angle of 180. You have a joint line obliquity angle of probably 1 degree of varus. And you probably have a proximal tibial angle that's about 3 degrees of varus, right? So you're not an outlier in any way. You're 180 degrees, right? And you restored them to normalcy. That's a sweet spot case.
So this brings up an important topic that at least here in the audience that's local at AAHKS we talked about, is that the way Dr. Manning's looking at the knee is the way I looked at the knee for quite a while, is how does it play out to our mechanical alignment concepts? Are we deviating from that too much? But when you assimilate to KA, then all of a sudden those thoughts sort of disappear, because our target has nothing to do with where the hip or the ankle is. This knee was done with PSI. We never knew where the hip and the ankle was because we used only an MRI to do planning. And how did we restore back to a nice alignment, the patient's pre-arthritic alignment? We just filled in the worn areas. So our target and the way we look at the knee is entirely different with KA, and I will encourage you, as you make the transition, you will start to look at the knee differently, and you will start to not think about, do you put the tibial component in varus? I was asked that a little earlier. I said, no, I restore the patient's pre-arthritic joint line. So although it may look varus to a mechanical alignment person, for us, there's no varus at all. And I think that's why we just don't see much varus tibial loosening with KA.
Yeah, your surgical outcome were coincidental to the guardrails. Yeah.
So here's one.
I got a question.
Let's go to valgus, because I saw that it looks like Jonathan Bedorczyk at Special Surgery sort of moved through the varus people. He's pretty happy with them, and now we have valgus. So I'd like to share with you one of my other early patients that, let's see here. All right, let's do this. So this lady, she's passed away, Dorothy Golden, and she taught me a lot about the valgus knee. What do you think, Pam? Lucas?
Looks a little valgus to me overall.
Does, doesn't it? Jonathan?
I agree. Scared.
David?
Yeah, so that looks like a mechanically aligned total knee, right? So that is, you've got hip adduction and a slight varus femur, and that's why you've got the valgus.
I'll submit to you that the valgus, a lot of it is coming from what I call a valgus tibia. So if you can see my pointer, if you go about 1/4 of the way down, you'll see that tibia makes a deviation into valgus.
Sure.
And when you take care of varus players, soccer players, become total knee candidates, or people from Asia, their tibias go down about 1/4 of the way and they make a big beeline to the midline. And you see that in the runners and the NBA players. And that's caused by a bow in the tibia, either varus or valgus. So I got that, and I thought, what happens if she sees someone in the neighborhood and is mad at me? That's what she looks like clinically. Lucas, what do you think?
Looks a little valgus.
What about the other side?
Looks valgus as well.
So what do you think about this? Does she have a deformity in the left knee? Jonathan, do you see Dr. Bedorczyk, do you see a deformity in the left knee that places that leg in excessive valgus?
Yeah, I mean, that tibia is very bowed. She's got a very flat foot.
Well, if you actually expand up the CT scan, she actually is wearing medially in her left knee. And if you ask her how the knee recovery was compared to her hip recovery was, and both of those hips were done by one of the Yang brothers, she said the knee recovered much faster and was happy as a lark because her knee is now straight to her. So when you have a valgus person in the pre-op area and you're going to do kinematic alignment without restricted correction, if the lady or the fella says to you, "Doctor, are you going to give me a straight leg?" I say to them, Mary, I'm going to straighten your leg like it was when you were 20 before you got arthritic, and that will be the only thing in your 70-year-old body that's 20 years old. And they get it because they've always been that way. So this lady, just like Mr. Milkcast taught me, Dorothy Golden taught me this. And I remember showing this at a View Medi course with Leo Whitesides and Bob Booth. I thought, I'm just going to see where they're coming from. Leo says, you left it crooked, you didn't straighten it out, and blah, 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 which is what I expected to hear. But Bob Booth said, I learned a long time ago, you don't want to overcorrect the valgus knee, which means beyond past in general what the pre-arthritic alignment was, because then the lateral side's tight, and you create all these issues. About what else do you want to see? Well, here's a lady. Let's look at a bad deformity.
Can you talk to me about
what would you do here, Dave? Would you do some sort of restricted KA on this, or would you just go straight to MA and just leave that for another time after you have experience with, say, the varus knee?
Well, I'm looking at the patient's right leg, and I can't tell you what their alignment is on that clinical picture. The hip's internally rotated a little bit. It's got a couple degrees of flexion contracture. I bet you if you lift it up, straighten it out, it's not as valgus as it really looks.
Well, let's get an X-ray.
There we go.
What's going on with the MCL, Dr. Fedorchik?
Well, it can stretch out, but it might be stretched out. I have to examine it. But
how about you, Lucas? You think the MCL stretched? Maybe he's not hearing us too well, but this is the one thing.
I'll dive on that one, Steve.
It's about 30% of my knees, probably 25, 30% are valgus. You find the MCL's pretty good. Why does that joint space look open medially? Because she has a flexion contraction. And even though that was supposed to be taken with the knee in full extension, it's probably in 15 or 20 degrees of flexion, which then relaxes the MCL relative to its extended position. And when she's standing up, the medial side looks like it opens. So we don't really see this stretch out of the medial collateral ligament with these valgus knees. What about the lateral femoral condyle? What are your thoughts, Dr. Manning, about the hypoplastic lateral femoral condyle? Is that something that we should pay attention to, or how do you look at this valgus knee? What makes it valgus?
So the hypoplastic lateral condyle is a frequently talked about but rarely seen phenomenon in the valgus knee. And I think that this person has a perfectly normal lateral condyle. I think they've got some obvious cartilage wear. There's some very mild squaring of the lateral condyle, but this is not hypoplastic.
How about you, Dr. Fedorchik? You agree with that?
yeah, I agree. It's not hypoplastic at all.
I'm going to save a question for you in a minute, Lucas. So I think that everybody sort of agrees. So this is a paper, because I was trying to figure out back in 2008 and 9, about this hypoplasia. Is it really hypoplastic or not? So you'll see there's a middle author there. It happens to be my daughter. She's a cardiologist. Anyway, we assessed the radii of the medial and lateral femoral condyles in the varus and valgus OA knee. So this is a typical example of a valgus knee. That is the medial hemijoint, and there is the lateral hemijoint. So you can put a best fit circle to the circumference of the bone from 15 to 120 and propagate it across, and it's the same. It's the same. We had, I think, 44 valgus knees out of 100-something, 120 valgus varus or something. So a pretty good sample size. So what makes it valgus is the lateral condyles proximal to the medial condyle. So when you do MA and you cut the femur in varus and you hardly cut anything on the lateral side, you have just overloaded that lateral, and you just got to start cutting a bunch of stuff. You can plan your resections with this. Or once you understand kinematic alignment, you don't have to put the x-ray up to do this operation. So I just had a resident from UC Davis down for a month. He never saw an x-ray in the operating room. Because we're looking at the surface of the bone and we're correcting what is worn. So this is what it looks like post-op. Lucas, any problem with that?
No problem.
Okay. Here's the long leg. You can see what do you think about the joint lines, Dr. Bedorchik?
Restored to native.
Yep, and it's done by just following. A lot of you spoke nicely about the verification checks and the caliper measurements as this assembly process. So when you follow that, and I think Dr. George, you said at the end, I'm trying to make a perfect knee. And I think that's everybody's goal. But when you follow it, you end up with this type of situation. And we don't like to flex the femoral component because if we flex more than 5 degrees, 10 or 12, then you can have a tracking problem because the femur is too distal. And we want to match the slope. Because if we're retaining the posterior cruciate and we do too much slope, the flexion space gets loose, and then you start to edge load the back of the base plate, and either the insert wears or the tibia subsides posteriorly. So all the KA complications that we have identified are all sagittal positioning problems of the components, not the varus valgus. So
Can I ask you a question real quick? Can you tell me about native ligament laxity? What's your goal? How do you want that knee to feel?
So that's an excellent question. So if you look at, let me ask a question to the audience real quick. How many of you do arthroscopy as well? Good, at least about half the hands go up. So when you do a scope, Dr. Bedorchik, do you ever look at the medial and lateral compartment with the knee in full extension?
No.
You can't get the scope.
You can't.
Because it's a tight rectangular extension space.
Yep.
I will tell you that everybody in Dallas that does not have a problem with their knee has a tight extension space with manageable BB laxity, and that's why we were taught that the knee is a rigid body in extension. So, Dr. Bedorchik, if you want to take out a medial meniscus, what flexion angle would you put the knee in to do so?
Usually around 30 degrees or so. It opens it up.
Perfect.
Nice. Yeah.
And then what happens? The joint opens a little bit, doesn't it?
Yep.
So that tells you once you flex the knee, the ligament length never changed. It's just its resting length is less because of the curvature of the bone. Now, let me ask you this question. Are all medial meniscus easy or the same to take out, or are some easier and harder than others?
Some are easier than others.
You have, so for me, I have some trouble with some medial meniscus to take them out. Why? I can't open the joint that much. Others you drive the car in. These are people with a torn ACL, nothing else wrong with them, or maybe just an isolated meniscal tear. So what's it tell you about the laxity of the knee? In full extension, the BB, it's tight. Once you flex, the medial side opens a little bit. But what about the lateral side? Is it easier to take out a lateral meniscus than a medial meniscus? Because once you flex, the lateral side becomes more lax, and you have a trapezoidal gap after full extension. If you want the knee to feel right, you have to achieve two goals. You have to maintain that trapezoidal gap when you flex. So therefore, hence, the concept of gap balancing from a knee's point of view is not compatible with a normal functioning knee. And the other thing you want to do is replicate that degree of trapezoidalness, because it varies from patient to patient. And you do it indirectly when you follow the verification checks in the operating room that we've outlined with the technique. Because some people are a little more laterally open than others. And if you shut them down, they don't like it. So ligament balancing for us, the real point of interest is not the ligament balance, but the forces in the compartments. So we want to replicate the medial and lateral tibial compartment forces, and we have several papers out on that where we do that with kinematic alignment, and it cannot be done with mechanical alignment, even after ligament releases. unless what? Unless you put the knee in kinematically correct by mistake. So if you strive for alignment and you get kinematic alignment, which can happen, then everything's pretty good. And I think that you all do kinematic alignment because some portion of your patients are kinematically aligned, and that's why they do so well. That's a point of view. Well, I think we are 9 minutes over, and maybe it's time to thank the persistence and doggedness of our three speakers, as well as Dr. Spanier, who can't join us today, for their excellent talks and for their insights. And I hope that you've seen that we have academic physicians from around the country looking at kinematic alignment, training their fellows and residents, but doing it in a cautious way, starting off with easy knees first, and you build the repertoire as your confidence grows. And if your confidence doesn't grow, then you don't move on. But we're in the practice of medicine. I've stayed in the practice of medicine at the age of 66, and I still try things that I think might help our patients. So I thank you very much for your attention. I thank Medacta for sponsoring this symposium, and I hope you have a great day and stay COVID